tonight's live Q&A. My name is Sara Arian. I'm a reproductive endocrinologist and infertility specialist here at Boston IVF. And I am happy and excited to be here tonight. As most of you may know, this week is National Infertility Awareness Week. And this subject is very near and dear to my heart. Unfortunately, infertility is one of those things that we oftentimes don't really get to talk about, share about. It's oftentimes mixed with a lot of stigma, and there's a lot of just surrounding stigma around the topic of infertility. And we all know that it's a disease. And we know that it can impact many couples, many individuals. Unfortunately, 1 in 9 couples are found to have or be diagnosed with infertility due to different causes, different reasons. And it's important to talk about it. It's really important to address it, to break the stigma surrounding it. And so tonight, I'm really hopeful that we can share some of your experiences. We can go over some of your questions. I'm happy to address and answer these questions for you. So I'm just going to go ahead and get started and go right into these questions. I see them kind of popping and coming, and I want to make sure that I get as many as I can answered for you. So hopefully you'll find it useful. So the first question that I got, how long after initial testing, which is the initial infertility evaluation, HSG, ovarian reserve testing, blood work, ultrasound, etc., I can begin the process of IUI treatment? So that's a great question. And typically when you see a fertility specialist, things that you need to expect with your very first infertility consult or visit would be some baseline fertility testing. So your physician would want to do some hormonal workup testing, checking ovarian reserve, also anatomical structural testing and evaluation, including a pelvic or a transvaginal, oftentimes ultrasound, HSG or hysterosalpingogram to assess the fallopian tubes and evaluate patency of the fallopian tubes. If applicable for a male partner, there is going to be some blood tests and genetic testing and also sperm analysis that would be ordered. And so typically we would want you to have all of these testing done and completed. And once we review all the test results, we can come up with a plan depending on the test results, depending on the results of the evaluation. We would like to address and fix whatever needs to be addressed first, and then talk about different treatment options. And so IUI or intrauterine insemination is definitely a treatment option. And that usually is a great option as long as there's adequate ovarian reserve, as long as there is normal sperm concentration and normal sperm parameters, and as long as the fallopian tubes are patent and open and not blocked. And so typically by the time that your physician reviews all the testing, as long as you're found to be a good candidate for IUI, it would take at least a few weeks. I would say probably 4 to 5 weeks pending insurance approval for you to be able to start the process of IUI. Next question is about PCOS. How common is PCOS? I asked my OB and primary care 12 years ago, and I had it, but Boston IVF finally diagnosed me. That's a great question. So PCOS, polycystic ovarian syndrome, is a very common reproductive condition. It's a very common hormonal condition that many women during their reproductive years can be diagnosed with. And in fact, many women who are being seen with a diagnosis of fertility or infertility, or who have difficulty conceiving, may end up being diagnosed with PCOS. So it's definitely a very common condition. In order to diagnose PCOS, you need to have 2 out of 3 criteria to be diagnosed with PCOS. Number one criteria will be history of irregular menstrual cycles or absent menstrual periods. Women who have history of skipped months where they don't get a period. Number two criteria would be any clinical or laboratory evidence of elevated androgens. And androgens are male type hormones, including testosterone, and all females, all women, they have androgens. Our ovaries are capable of secreting androgens, including testosterone. Now, women with PCOS are sometimes found to have elevated levels of androgens, including testosterone or DHEAS, and that can sometimes be diagnosed based on laboratory testing, and sometimes can represent itself as clinical symptoms such as acne, skin breaking out, hair thinning, or hair growth on uncommon areas such as face, chin, hair growth on the breasts or on the abdominal area. So that's one criteria. And then the third criteria would be polycystic appearing ovaries, and that is something that we can evaluate based on an ultrasound. So on the ultrasound, if there's evidence of presence of 12 or greater than 12 follicles, which are fluid-filled sacs that contain eggs on one ovary, that would indicate a polycystic ovarian morphology, and that would be a criteria for PCOS. So a woman does not have to have all three out of three criteria to be diagnosed with PCOS. 2 out of 3 criteria can still make the diagnosis of PCOS. So you don't necessarily have to have the polycystic ovarian appearing ovaries on the ultrasound. You don't necessarily have to have symptoms of elevated androgens, but 2 out of 3 criteria can diagnose you with polycystic ovarian syndrome. I have had multiple miscarriages. What are the additional testing or treatment to help diagnose what is happening? I'm so sorry for the fact that you have been experiencing these losses, pregnancy losses, miscarriages. We know that unfortunately miscarriages are common. Again, we don't really get to talk about them, or many don't share about early pregnancy losses and miscarriages, but sadly they're common. Up to 25% of pregnancies, 1 in 4 pregnancies, can unfortunately result in an early miscarriage. And so when an individual has had 2 or more than 2 prior miscarriages, and they don't necessarily have to happen back to back, we would like to start the process of evaluation for recurrent pregnancy loss. And so as part of the evaluation, we would like to order some hormonal testing, blood work, to make sure from a hormonal standpoint, there are no causes for miscarriages. We would also like to order some structural anatomical testing and evaluation, including pelvic or vaginal ultrasound, and oftentimes some type of testing to assess inside of the cavity of the uterus, uterine cavity. So that may be by ordering an HSG, hysterosalpingogram, to assess both the uterine cavity and the fallopian tubes, as well as other forms of testing, including a saline sonogram. We would also like to order autoimmune testing. So from an autoimmune standpoint, there are conditions such as antiphospholipid antibody syndrome, which can increase the likelihood for developing miscarriages or early first trimester losses. So we would like to assess for any autoimmune issues. And then most importantly, from a chromosomal standpoint, we would like to check to make sure that there aren't any subtle chromosomal changes, rearrangements. These are oftentimes known as chromosomal translocations, inversions, that we would like to assess by ordering chromosomal karyotype, which has to be performed for both partners in order to evaluate for recurrent pregnancy loss. So my suggestion in these cases, if you have experienced 2 or greater than 2 losses, would be to definitely see a fertility specialist to start the recurrent pregnancy loss workup and talk about options moving forward. Keep in mind that oftentimes we do order all of the testing, and sometimes, unfortunately, all the test results can come back normal. And I say unfortunately, this is good and bad because well, this is great because we can't find a reason as to why you're having miscarriages, but at the same time, it can be very frustrating because sometimes we desperately do want to find a cause or etiology that we can hopefully help treat or fix and correct. But oftentimes the etiology is unknown, and nothing will come up based on the testing. And in those cases, you could still talk to your physician and see what are some of the options that they can offer you for your future conceptions in order to prevent this from happening. Thank you for doing this at this time of the day. You're very welcome. And I'm happy to be here. Two hope to be moms here. Congratulations in advance. I'm 33 and she's 42. We know the younger the better, the X. How about carriers? Does age matters for who carries a baby? Thanks again. Yes, you're very welcome. Again, I'm very happy and excited to be here tonight. So this is a great question. Typically for the partner who's undergoing fertility treatment using their eggs, whether it's the process of IUI or IVF, obviously we like to see good quality, better quality eggs, and age will be number one important factor determining a woman's egg quality. And obviously a quantity or AMH, anti-Mullerian hormone level, is also an important factor. So we typically like to have higher egg quality and higher egg quantity. So egg quality, egg quantity will determine success with IVF or really any type of fertility treatment. As far as transferring an embryo into the uterus of the partner who's going to be carrying the pregnancy, that we may not care as much about age at that point. And I say care, well, we obviously don't want the person who's carrying a pregnancy to be much older, but at the same time, as long as we have done some basic evaluation, evaluating the cavity of the uterus, and as long as that individual is found to have a healthy uterine environment, then we're less concerned about transferring those embryos into your partner's uterus, even if they're in their early 40s. So as long as the uterus is found to be an optimal environment, we're less concerned about age, so to speak, at that point. Next question. How do you know if you have the MTHFR gene and how important it is to test for it? At what point in the if someone is trying to conceive process, would you recommend testing for it? To be honest with you, the data is all over the place about MTHFR, and we know that typically a certain percentage of general population can be a carrier for MTHFR, and different physicians approach this differently. In my practice, I don't routinely test or check for MTHFR. And even in the setting of having had prior miscarriages or losses, I don't routinely test for this. I just advise all my patients who are actively trying to conceive, whether or not they've experienced prior miscarriages, to be on a prenatal vitamin with adequate amount of folic acid. And I think that's all that you would need. But then some physicians would routinely screen or would screen you if you have had history of prior losses. But honestly, there's no data to support routine screening for MTHFR. So I would not really worry about getting tested for that condition. Another great question. I froze my egg several years ago because of a genetic mutation, BRCA1 or BRCA1, which is a gene that can increase the likelihood for developing early onset breast cancer, ovarian cancer. So I'm glad you found out about this and you froze your eggs. My fiance just found out that he has the same genetic mutation. Is there a way to test his sperm for the gene before potentially mixing it with one of my eggs that does not carry the gene. So unfortunately, there's no ways of genetic testing of the sperm or the egg. An egg is a single cell, is a single large cell. There's no ways that we can genetically biopsy an egg, and that's why when a woman undergoes the process of egg freezing, we always tell them that there's no ways we can genetically test and biopsy the eggs for us to tell you which ones are genetically normal eggs. But the best way to go about this would be to do the fertilization, meaning to let the sperm fertilize the eggs and create embryos. And once the embryos have been created, then we can get the embryos tested for this condition. So there is the PGT-A testing, pre-implantation genetic testing, which can be performed. And because an embryo has hundreds of cells, we can easily take a few cells and send those cells for biopsy for genetic analysis, and not only determine chromosomal status of your embryos, but also test them for specific genetic mutations. All right, moving on. What is the difference between HSG and a Hypcosy? What are the pros and cons of each? That's a great question. So HSG, hysterosalpingogram, is a test that we have had traditionally available since a long time ago. And this is an X-ray dye test of the fallopian tubes. And basically with this test, we inject or infuse a contrast solution, a dye using a catheter that is going to be injected inside of the cavity of the uterus. And we follow the dye as it's traveling into the uterus and goes into the fallopian tubes. And then we take X-ray images at the same time while we're injecting the dye. This test is a test that is being performed to evaluate the cavity of the uterus, making sure we evaluate the cavity for presence of any polyps, any lesions, any scar tissue. But at the same time, it's a great test to evaluate the patency of the fallopian tubes. Hypcosy is a slightly similar test. It's an ultrasound-based test, so we don't need to take X-ray images. With Hypcosy, we just inject some typically sterile saline fluid that is going to be injected inside of the uterus in order to expand and distend the cavity in order to see inside of the cavity better. And at the same time, by watching the fluid as it travels into the tubes, we can confirm that the tubes are open if the fluid is if we see bubbles around the tubes, confirming that the fluid is being spilled from the fallopian tube. So it's just, there are two different tests, but done for the same purpose: evaluation of the uterine cavity and the fallopian tubes. HSG, we have the ability to take multiple images. So sometimes it can be a little more accurate or better in the sense that multiple images can be obtained with HSG, and with the Hypcosy sonogram, it's just the injection of the dye, and we just have to kind of wait to confirm if we can see spillage of the saline from the tubes. All right, let's see, where was the last question? So next question, can you repeat the name of the syndrome that could lead to recurrent pregnancy loss? Yes, antiphospholipid antibody syndrome. And typically there's a criteria to diagnose APLS, or antiphospholipid antibody syndrome. There's clinical criteria, history of having 2 or more than 2 losses, sometimes having had a history of preterm birth that is associated with chronic hypertension or preeclampsia. And you need to also have laboratory evidence and evaluation confirming diagnosis of APLS, or antiphospholipid antibody syndrome. And that's when we order the serum antibodies, including lupus anticoagulant, antiphospholipid antibody, and anti-beta-2 glycoprotein antibody. Next question is, I froze my eggs and my husband and I are thinking about starting the fertility process. Well, congratulations to you. It's great that you were proactive about this. What are the steps and timeline from unfreezing until implantation? So let me just make one thing very just kind of clear and explain this. So oftentimes, and I get this a lot from a lot of my patients who see me for the process of freezing their eggs. And oftentimes the thought is that once you have frozen your eggs, you are obligated to use those frozen eggs without even trying on your own. And that should not be the case, meaning I highly encourage and recommend that once you're with a partner and you're ready to start trying, that you definitely start trying on your own. And if after some time of trying, depending on your age and obviously depending on your status, the rest of your testing, your ovarian reserve, then if the only option is to use these frozen eggs, to go ahead and plan on using those. So you don't have to by default plan on using frozen eggs. You definitely need to. Now, I don't know about your story, the details of your story, but just in general, just to kind of make a point here for the rest of the audience, just to make sure that you have started trying for some time, and if being unsuccessful, then the next step, one of the options would be to use these frozen eggs. And so the process basically involves having these eggs, seeing your fertility specialist, basically undergoing some up-to-date evaluation testing, mainly evaluation of the uterine cavity. If you're planning on having your embryos transferred, talk about the option for genetic testing of the embryos, if that's something that you are interested in. And then the process involves basically thawing, unfreezing the embryos, as you mentioned. The eggs, as you mentioned, and combining them with sperm for fertilization. And then typically, once the embryos have been created, we would grow these embryos for about a week or so to a more advanced stage embryo, which is called a blastocyst. And at that point, if you're interested in biopsying or having genetic testing done on your embryos, it can be performed. And then basically, if you're planning on having genetic testing done, then a biopsy sample has to be sent after you're taking a few cells from your embryos, and then the embryos have to be kept frozen until you know about the genetic status of your embryos before you can plan on doing a frozen embryo transfer. If the plan is not to have any genetic testing done and proceed with a fresh transfer, then once the embryos have been created and are found to be at an appropriate stage, typically a blastocyst stage would be ideal to perform a fresh embryo transfer. The uterus has to be prepared and ready by using different medication regimens, protocols, and then we would plan on performing an embryo transfer. So typically it does not take a very long time for a fresh transfer to be done using your previously frozen eggs. Next question. What is the current research on transferring 7-day embryos? My last IVF cycle created several 6-day or day 6 and 7 embryos. Why do some patients make more 6 to 7-day embryos? That's a great question. Really don't know why. Some embryos are just slower to grow and develop. And so we think that the time to blastocyst stage is important, an important aspect of embryonic growth and development. And typically the embryos that are faster to get to that blastocyst stage have a higher implantation potential. That being said, we have done some studies actually here in Boston IVF, looking at day 5 versus day 6 versus day 7 embryos to see which one of these embryos tend to do better. And typically day 5 and day 6 embryos tend to do better overall compared to day 7 embryos. With day 7 embryos, there's still a potential for implantation and for having these embryos develop into a normal, healthy pregnancy. However, that potential could be slightly lower compared to day 5 and day 6 embryos. And I want to say, based on the study that was done here in Boston IVF and based on the data from our lab, it was found to be somewhere around 35%, 36%. So slightly lower than 40% implantation potential for the day 7 embryo. Okay. And then next question is about uterine fibroids, one of the areas of my interest. So I've had multiple fibroids removed from inside of my uterus. I've also had 3 failed transfers with PGT tested embryos. All tests and blood work comes back as normal. What might be a reason that the embryos are failing to implant, and does it have anything to do with the previous surgeries? I mean, I'm sorry that you have experienced so much and you've had to go through a lot. I mean, there could be many, many reasons that I can think of. So the fact that you've had fibroids removed previously from inside of the uterus, that could increase the likelihood for scar formation. So your cavity, your uterine cavity definitely has to be checked again prior to undergoing another embryo transfer to assess for any scar tissue. And that scar tissue has to be removed and fixed prior to doing another transfer. But it could also be the embryos. I mean, at this point, having had 3 failed transfer, could still very well be due to your embryos, even if they're PGT-A tested. We know that we're transferring genetically normal tested embryos. We know that not all embryos have the potential capability of developing into a normal pregnancy, normal individual human beings. Although in your case, I would think that that's a less likely cause, since you've had 3 failed transfers and all of them have been normal. Because after transferring 3, after you failed already 2 PGT-A normal transfers, after transferring the 3rd one, the likelihood of success should be pretty high, about 95% or so. And so the fact that you have not been successful makes me worried that there may be some type of scar tissue formation or something going on, or either that or the fibroids may have, recurred and regrown. So your cavity, your uterus definitely has to be evaluated for that. Next question, I have done blood and HSG testing ordered by my primary care. Will I have to repeat those retesting? It was very painful. I'm hoping not, meaning sometimes some of the blood hormonal testing may have to be repeated depending on during which day or what part of your menstrual cycle the testing was done and what specifically we're looking for. Sometimes we may be looking for specific ovarian reserve testing that may not have been performed before. But oftentimes, I mean, for me, if the HSG testing has been done previously and has been reported to be normal, I necessarily don't want you to have to go through the testing again. And I'm sorry you had to go through that. It's definitely a very crampy test. So unless we have to, for whatever reasons, if the results were not conclusive or something unusual, abnormal, hopefully it necessarily does not have to be repeated again. Can you recommend supplements or vitamins or anything really a patient with PCOS can do prepare for IVF? Yes, that's a great question. Let's talk about supplements. And so really, when we talk about fertility supplements, there are a million different types of supplements out there. And I tell my patients that, you don't necessarily have to go purchase, spend money on purchasing all of these vitamins and supplements. The ones that are my favorites, so everyone who is, every individual, every woman who's trying to conceive has to definitely be on a prenatal vitamin daily with folic acid. And so that is any kind, any brand over the counter, which is recommended for everyone. I also do recommend taking COQ10 or coenzyme Q10, which is also an over-the-counter antioxidant. And that has been studied in multiple studies and can help improve equality based on a lot of studies that we have available. So it certainly is not going to be harmful and may have some benefits. So that would be CoQ10 or coenzyme Q10. And then for patients with PCOS, I do check hemoglobin A1C, which is a marker of your blood sugars. And if I'm concerned about insulin resistance or any metabolic abnormalities, depending on what your hemoglobin A1C level may be, I sometimes prescribe metformin, which is an insulin sensitizing agent, or sometimes advise you to take a supplement called Ovocetol, which is also an insulin sensitizing agent, which is not really FDA approved or a medication out there that can be prescribed. It's more of an over-the-counter supplement that can be taken in some with PCOS. Another great question, how much would subclinical hypothyroidism and Hashimoto's impact fertility? TSH level of 3.1 and TPO antibody level of 11. So that's not a high TPO antibody level unless you've had elevated levels in the past or the diagnosis of Hashimoto's. And so in these cases, I would want for you to be on levothyroxine, and I would monitor your TSH levels with the goal of TSH being less than 2.5. in cases when you have elevated thyroid antibodies, including TPO or a previous diagnosis of Hashimoto. So we do want to maintain the levels less than 2.5 for TSH when you're trying to conceive or undergoing fertility treatment. And once you do become pregnant, my patients who become pregnant, we're already on levothyroxine. Their recommendation is to increase your dose by 30% early pregnancy and to continue to monitor the levels. So I'm hoping that as long as your levels are well controlled, it is not going to have too much of an impact on your overall fertility, but we do want the TSH level to be less than 2.5 if you do have a diagnosis of Hashimoto or previously elevated anti-TPO. What is the average amount of IVF rounds a 29-year-old with low AMH usually has to have? That's a great question. And unfortunately, it's a little hard to answer, right? You are young. So a 29-year-old individual patient is young. And so you have the advantage of hopefully having good equality as long as you're healthy with no underlying medical conditions. It's frustrating that you're starting off with a low AMH, lower ovarian reserve. So it makes it a little harder to achieve a good number of eggs after one round of IVF. So starting with a low ovarian reserve, you just have to mentally prepare yourself that you are going to need most likely more than one round of IVF, but it also depends on the equality as well. Sometimes, you know, if you have great equality, even after one round, you may be able to achieve a good number of embryos. Versus oftentimes you're going to need more than one round of IVF. I would say at least like 2 or likely more than 2 rounds to achieve that number. So it also depends on your quality as well as a quantity. How much does stress truly impact your success rate and chance of getting and staying pregnant? Well, that's a great question. And, you know, stress is always harder to study, and it has multiple, you know, aspects to that. I mean, we know that we want you to be mentally, physically, emotionally, you know, in a good mental headspace while you're undergoing fertility treatment and in pregnancy. But you know, it's really hard to truly determine and define the true impact of stress on different aspects of, you know, fertility and pregnancy. But you know, you just got to try your best. Nothing is perfect, and we all experience stress and stressors on a daily basis. And you know, it's important to just manage it as much as we can. But truly, the impact is, we know that it does have an impact for sure, but the true impact is really unknown. 36-year-old female using donor sperm. If I have had expanded genetic testing and my donor had expanded genetic testing, would you still recommend PGT testing for chromosomal abnormalities? That's a great question. So when we do expanded carrier screening, we are screening you or your sperm donor or partner, if applicable, for autosomal recessive genetic conditions. And so it's important to do this screening because if you are a carrier for a certain gene and the donor is also a carrier for that exact same genetic mutation, then if you absolutely are wanting to use a specific sperm donor, you have to be aware that there is a 25% likelihood, 1 in 4 likelihood of possibly having an affected child offspring with this genetic mutation. And for that reason, IVF needs to be performed with PGT-M testing, pre-implantation genetic testing for that specific genetic condition. Now, to answer your question about PGT testing, there's another type of PGT, which is called PGT-A, and that's pre-implantation genetic testing for aneuploidy screening. And that's a test that can be available to anyone who undergoes the process of IVF. It's in addition to IVF. It is not covered by most insurances here in Massachusetts. And that's basically screening your embryos for any type of chromosomal abnormalities, including Down syndrome. So that can be done regardless, meaning even if you are found to be a negative carrier and the donor is found to be a negative carrier, you can still request to have PGT-A testing done on your embryos to screen for Down syndrome, other type of chromosomal abnormalities. And so typically we say that for women who are 35 years of age and above, PGT-A has been shown to help improve likelihood of success with pregnancy and IVF outcomes. If you're younger than 35 years of age, it may not necessarily increase your likelihood or chances, just because the likelihood for chromosomal abnormalities, if you're younger than 35 years of age, is lower. So hope that helps answer your question. I will try to kind of go over questions faster. Do fallopian tubes ever come unblocked? Mine were blocked 2 years ago. What is the likelihood that they're still blocked? Very highly likely that they're still blocked. Oftentimes when they're blocked, it's a result of some type of chronic infection, some type of previous sexually transmitted infection, sometimes as a result of having had multiple prior abdominal surgeries. Or endometriosis that can result in scarring of the fallopian tubes. And typically, if they were blocked before, there's a very low likelihood that this unblocked, unless previously it was an artifact or a false positive result on the testing. How many IUI attempts do you recommend if there are no known infertility issues just in the same-sex relationship before going to IVF? I would say typically about 3 to 4 rounds, maybe about 4 rounds. Typically standard is about 3 rounds or so. After really 4 rounds of IUI, we know that if you have not been able to succeed and become successful, the likelihood of getting IUI to work is not going to be as high. And so in that case, we would want to try to move forward with a more advanced type of treatment, which would be IVF. Next question, does it make sense to start treatment with ovulation drugs, trigger shot, IUI, IVF, etc., with a diagnosis of unexplained fertility, or does it make more sense to do more testing and try to explain the infertility first? That's a great question. The diagnosis of unexplained infertility oftentimes is very frustrating. It is called unexplained infertility, and that just means that there is something going on that we can't simply test for. And it sounds very frustrating because you've done all the testing and we can't find an etiology or reason for this underlying infertility, but truly there is some type of etiology. It's just that we can't test for it. There may be some genetic issue that we can't test for. There may be an issue with the egg quality that we can't necessarily know about or test for. There may be an issue with sperm quality. Maybe the sperm is not capable of fertilizing the egg appropriately. Maybe the tubes are not blocked and open, but from a functional standpoint, they're still, from an anatomical standpoint, the tubes may be normal, but from a functional standpoint, there may not be functioning normally. And so that's why it's called unexplained. And so standard recommendation for unexplained infertility is that you could try with a few rounds of IUI, but not really more than 3 rounds of IUI. And after that, with the ovulation induction medication, and then after that to move forward with IVF. So when they looked at using ovulation induction by itself without IUI, or the use of IUI without using the ovulation induction, the oral fertility medication, they did not show any benefits in doing those alone, but maybe some benefit in doing the combined treatment with the oral fertility medication and IUI, and really after 3 rounds, if unsuccessful, to move to IVF. For someone who's already ovulating, why does taking an ovulation drug like Clomid or letrozole in conjunction with IUI improve your chance of success if taking that drug with or without IUI doesn't? I mean, that's a great question. Sometimes even if you're ovulating, we do prescribe an oral fertility pill to just kind of help strengthen or boost your ovulation. Also, depending on what your ovarian reserve testing and what your age is. Sometimes the goal is to make your ovaries develop not only 1 mature egg, which you would typically do per month, but to develop more than 1 mature egg. And by doing so, increase the likelihood for having a genetically normal egg that can be fertilized with sperm. And that is thought to help. So there may be an additional benefit in having you take an ovulation medication in order to help boost and strengthen your ovulation in order to make you release more than one egg, knowing that not all of our eggs are genetically normal and capable of becoming fertilized with sperm. So let's see. What can you do to try to uncover the causes of infertility after getting a diagnosis of unexplained infertility? Again, I hope my previous answer helps. I mean, we do all the standard testing. Unfortunately, when unexplained, it becomes a little more challenging, difficult, because there could be many, many reasons. Our tests and our evaluation panels and testing are not just quite as advanced to look for those or to identify those causes. So nothing really beyond the standard testing, including testing of the ovarian reserve ovulation, structurally testing the fallopian tubes, uterine cavity, and sperm parameters. Can I start the analysis for me and my husband, and how? I think you mean start the fertility evaluation. Yes, absolutely. I mean, all of us here at Boston IVF, we have lots of physicians, lots of locations. We see patients in person. We see patients remotely on Zoom, and we're more than happy to see you. So you just have to call, make a new patient consult for you and your partner to be seen and evaluated, and we can start the process. We're happy to help. How much CoQ10 do you recommend taking for women or men? What brand from the supplement do you recommend? So typically any brand over the counter for CoQ10. There's also Therologics, and they make fertility supplements, and they have NeoQ10. And that's also something that you can order online through Therologics. But anything really over the counter, CoQ10 should be sufficient. And the recommended dose would be 600 milligrams. So if you're taking the 300 milligram tablets, that would be 2 tablets a day versus the 200 milligram tablets of CoQ10, which you have to take 3 times daily. Follow-up question about subclinical hypothyroidism and Hashimoto's. I'm on levothyroxine now, but was trying to conceive for 7 cycles before that, and I'm wondering how much of why I didn't get pregnant during those 7 cycles could be attributed to my elevated TSH levels and the presence of anti-TPOs. Should I count those tries or not? Have tried 4 cycles since starting levothyroxine with no success, even though TSH is down. So I think, I'm sorry that you have not been successful, but it would make me think, I mean, the fact that it was taking you a long time, TSH could have had an impact on your ovulation, but the fact that you have been trying and started formally, officially trying, I assume 4 cycles and still not being successful, that would make me think that there's something beyond just the TSH level, if that makes sense. So there's something definitely going on that needs to be, addressed, and you will hopefully benefit from getting some type of fertility treatment done, because typically when the setting of TSH abnormalities, it's if TSH is the only factor that is impacting your ovulation, typically once we start you on levothyroxine and the TSH level is lowered, then you should be able to ovulate regularly and normally and be able to conceive pretty quickly. Do you know if Ozempic can be taken during stims? Will this affect egg quality? How long before starting the process should I discontinue taking the medication? That's a great question, and that's actually becoming a little more popular these days. Many patients are on the injectables for weight loss that are being prescribed by their physicians or weight loss clinics. And the reality is that we don't have any data, really. We don't have any long-term data on Ozempic and other types of weight loss medications. And so really unknown as to if they're going to impact your egg quality. And so my preference would be for you to stop prior to starting the process of IVF. Obviously you can you won't be able to take it for sure during pregnancy. So likely would like to stop a few weeks before starting the process of IVF, just because we don't have enough data about the effects and impacts on egg quality. And at the same time, keeping in mind that obviously elevated BMI and obesity can negatively impact egg quality. So if this is something that is going to be helping, then obviously we want you to be on it, but also consider making lifestyle changes and modifications right before starting an IVF process, and possibly stop taking the medication, but really unknown. Does a vasectomy have an impact on sperm over time? No, I'm not aware of any data to suggest that sperm quality after vasectomy will necessarily be affected or lower, but we do know that once that vasectomy has been reversed, if there is an indication for vasectomy reversal, if the individual is found to be a good candidate for vasectomy reversal and they undergo reversal, we just have to give it some time, typically about 2 to 3 months before sperm can be checked and sperm parameters can be checked to make sure that there's adequate amount of sperm and the sperm parameters look normal or look good before proceeding. 28, 2 children. My last miscarriage before my new spouse has 1% morphology, but normal count and motility. Is there any way to increase any chances? Naturally, unfortunately, we can't afford to do IVF or IUI. Well, I'm so sorry about that. And so listen, a sperm morphology, couples many men may have abnormal sperm morphology or lower sperm morphology and still able to conceive naturally. However, if it's taken you a very long time, then that may become a little more challenging or difficult. So really, the data, again, it's very mixed about improving sperm morphology in men using supplements. And there have been some studies on antioxidants and CoQ10 and vitamins, and it's certainly not going to hurt to be on one men's daily multivitamin or take some additional CoQ10 and get his vitamin D level checked to make sure he's not vitamin D deficient. But those may not have a lot of impact, over time. So after some time, if really not successful, then you would have to, pursue a fertility treatment if you're not able to conceive. Next question is that I have a pituitary tumor in my pituitary gland, experienced pituitary apoplexy due to a severely enlarged pituitary gland. Could this tumor be affecting my fertility? Yes, yes, indeed, because remember, pituitary gland is the gland that is in charge of secretion of FSH and LH, and those are important hormones to communicate with your ovaries. And so if it's if it was a large pituitary tumor, and if you did experience some damage to the pituitary gland, then you may have to be evaluated to make sure you have adequate levels of FSH and LH hormones, and you are not, you don't have a condition called hypogonadotropic hypogonadism, which is when the amount of those hormones are pretty low and you're not, and that can impact your ability to ovulate and conceive naturally. Also, does bacterial BV, bacterial vaginosis, affect your ability to get pregnant? I've heard it can lead to PID. Unfortunately, I get it chronically. No, not necessarily. So BV is a frustrating type of infection. It is not necessarily sexually transmitted and does not necessarily impact or damage your fallopian tubes or other reproductive structures. And it is not uncommon for women to experience chronic BV, and there are special types of regimens that can be used in order to treat that. But I'm hoping that it's not something that would necessarily lead to PID or damage to your fallopian tubes. What does an AMH level of 1.1 mean for a 32-year-old in terms of ovarian reserve, early menopause, etc.? What recommendations would you make based on this result? That's a great question. So again, another point I would like to make about AMH tonight for everyone. So AMH, or anti-Müllerian hormone, is a marker of your egg reserve, your egg count. And so it's a test that we use to determine your ovarian reserve. And so AMH is not a marker for pregnancy. That's important to know. There are many women out there in the society that end up becoming pregnant without any difficulty and issue while they have low AMH levels. And so it's not a marker for pregnancy based on AMH level. We can never tell you that you won't be able to, or you can't become pregnant. Sometimes a lower AMH level can make it a little more difficult for you to conceive on your own, and you may require to undergo fertility treatment. It also does tell us that with lower AMH, lower egg quantity, if you are to undergo the process of IVF, sometimes that may make it a little more difficult to achieve an adequate number of eggs, and you may need or require more than one round of IVF to be able to get a good number of eggs, oocytes and embryos. And then for a woman with a lower AMH compared to another age-matched woman, same age with a higher AMH, the chances that the one with the lower AMH is going to run out of eggs sooner is going to be higher compared to the other person with a higher AMH level. And so AMH of 1.1 for a 32-year-old is overall normal, maybe slightly lower than average, because typically we would expect the level to be anywhere from 1.5 up to 1.82 at your young age of 32, but it's not terribly lower. And so it tells me that you don't have a very high ovarian reserve, meaning you don't have tons of eggs, but it is certainly a normal number. Thoughts on moderate use of marijuana while trying to conceive for anxiety and pain management rather than over-the-counter pain medications? Does it really reduce your ability to get pregnant? The chemical compounds are very different than alcohol and cigarettes, which is typically which we are typically told to avoid. Well, I'm not a fan, right? Anything that can be toxic, anything that can be slightly chemical toxic to the eggs and the sperm, I'm not a fan of, especially when you're trying to conceive. And there is some data to suggest that chronic use of marijuana can increase the likelihood for having recurrent miscarriages and pregnancy losses. So I would try to avoid that. Also, we don't really know about the harmful impacts that it can have on egg quality and sperm quality. Can I take baths after IUI? I've heard that it may affect implantation. As long as you're not exposing yourself to high temperatures and hot baths, it should be fine to take, regular baths. After experiencing a biochemical pregnancy through IVF with frozen embryo transfer, how likely are your odds for success if you're doing it again in the less than a year? Still high. I mean, I'm so sorry that you experienced that, but I'm sorry. But I'm hopeful that with your next embryo transfer, we can hopefully make it successful for you. Anytime we're transferring an embryo, obviously, depending on your age or your other, underlying factors, with a frozen embryo transfer, the likelihood for success can be anywhere from 50 to 55%, sometimes even higher in the setting of having a genetically tested normal embryo. And so I'm definitely hoping that your next one is going to be a successful one. What would a low FSH early in the cycle indicate? 0.99 cycle day 3. So typically we like to see FSH being low when you're in the early phases, in the first few days of your menstrual cycle. In contrast, a high level of FSH would be concerning for premature or early menopause. Now, we also don't want the FSH and LH level be too low. So that level of 0.09 would be a little concerning to me. It definitely has to be rechecked unless you're on birth control pills or anything that may suppress your FSH level. We want the FSH and LH levels to be at least 5 and above. Levels lower than that may indicate hypogonadotropic hypogonadism. I just turned 39 with low AMH. I've had 2 failed IVF cycles. I'm so sorry that you have experienced that. Is it safe to start another cycle right away? What can I do to improve my chances of getting pregnant using my own eggs or sperm? That's a great question. I mean, yes, I would say if you're 39, you know that your ovarian reserve is low. You've already failed 2 IVF cycles, probably. I mean, time is very important. Time is an important resource that we're never getting back. So I would say it's probably reasonable for you to be proactive and move forward with another round of IVF and try to bank as many normal embryos as you can possibly get, and just mentally prepare yourself that you may require, a few rounds of IUI in order to be able to achieve that. And unfortunately, there's not much that we can do to help improve egg quality because it's mainly your age. Sometimes it's, genetics, familial factors. But taking those supplements, prenatal vitamins, making sure your vitamin D is adequate, making sure you're taking CoQ10 is certainly not going to hurt. If all of the tests are normal and implantation is failing, is it worth to have exploratory laparoscopy to confidently rule out endometriosis? It can be. I mean, if you have strong indications or symptoms suggestive of endometriosis, a laparoscopy, diagnostic laparoscopy could be performed to assess and evaluate your pelvic cavity for endometriosis. But we also want to make sure that the cavity of the uterus is completely normal. You don't have any fibroids impacting implantation of an embryo. We also want to make sure you don't have any chronic tubal dilation, hydrosalpinx. There's also a test, it's called Receptivo, which is a type of an endometrial biopsy that checks for inflammatory markers, including BCL6, which can indicate endometriosis or chronic pelvic inflammation. And in these cases, when a Receptivo is being performed, if it comes back positive, although the data is really not strong surrounding Receptiva, but it's something that can be done in the setting of having had multiple failed implantations or recurrent implantation failure, as sometimes putting you on Lupron to downregulate and suppress the uterus and the ovaries, and then moving on to an embryo transfer may help with the success. So I think we're almost coming to an end. Thank you so much for joining us. This is going to be an exciting week with lots of events during the National Infertility Awareness Week. And we are hoping to see you there. And I hope this session was helpful in addressing some of your questions. So thank you so much for joining us.